Good morning, everyone. I'll be presenting grand rounds today. I think we're still waiting on a few more of the faculty members to join.
Um, as we are waiting for our faculty to join, I sent all of you an email on Monday with regard to our department retreat. So this is the third annual retreat. We have freed up everybody's clinical commitments for that day, except for, if we have any emergencies. I would love for all of you guys to look at the agenda for the retreat and please respond directly to me. I don't want the boxes to be clogged for others, so just send it to me, your suggestions. And we look forward to, there are multiple small breakout sessions planned, so each of you will have an opportunity to participate and your opinion and ideas matter. And we're looking forward to a fun and engaging retreat. So again, please look at your emails. If you have any comments, let me know if you have any questions. Okay. Over to you, Hunter.
Thank you, Dr. Blasi. Uh, Let me share my screen. Let's see. All right. Today I will be presenting grand rounds on sacral neuromodulation. I have no disclosures. Overall learning objectives we circulated in the lecture abstract for today is to review the neurologic control of voiding, to understand a brief history and development of urologic neuromodulation devices, and to briefly discuss some of the indications for and the technical steps in proceeding with sacral neuromodulation. Um, Here's a brief outline of the talk. We'll start reviewing the anatomy and physiology of voiding, specifically looking at the neurologic control of it. We'll talk a little bit about the pathophysiology of overactive bladder, one of the primary syndromes that sacral neuromodulation is used to treat. And then we'll go over some of the basics and history of SNM, talk a little bit about indications and the recent 2024 um, SUFU AUA guidelines for AUA management. Go briefly through some of the techniques for installing, focusing on the stage one implementation, and then talk a little bit about some of the initial trials of outcomes and efficacy. And then if we have time, we have some SASP questions we can go through with residents just to brush up on this, especially in light of the upcoming in-service exam. Um, so starting with anatomy and the neurologic control of voiding, innervation of the bladder is accomplished with a relatively complex interplay between the three distinct components of the nervous system. Mainly for the sympathetic nervous system, this is accomplished through the hypogastric nerves, starting from the levels T10 through L2. And these provide sympathetic innervation to both the bladder neck and the detrusor muscle. The neurotransmitter responsible for these signals is primarily norepinephrine, which can cause detrusor relaxation through beta receptors, and then internal sphincter contraction through alpha receptors. And we're familiar with those both through the pharmacology of bibegron or mirabegron for the beta agonists, and then your alpha blockers, Flomax and the like, with the action more at the bladder neck and the internal sphincter. Um, in terms of parasympathetic innervation, this is accomplished through the pelvic nerves emanating from spinal levels S2 through S4 nerve roots. Um, and these innervate the detrusor muscle primarily with acetylcholine as the primary um, neurotransmitter. The somatic nervous system innervates the external urethral sphincter and provides voluntary control, and also
So sorry.
emanates from the S2 through
All right.
S4 nerve roots. Um,
But that's like the whole procedure. Should
Hey, Udai, will you guys mute, please?
the afferent, both afferent and efferent fibers are in place in these, and the afferent fibers carrying sensory information back to the central nervous system, and efferent carrying motor signals to the sphincter and the detrusor. Looking at the physiology of voiding, moving on from the anatomy, primarily we talk about both the guarding reflex, which promotes storage and is accomplished mainly via the sympathetic and somatic systems. And here we can see there's activation of both the external sphincter and then relaxation of the detrusor in that guarding reflex. And then the voiding reflex is accomplished primarily through the parasympathetic system and leads to detrusor contraction, and also requires relaxation of the external sphincter as the initiating step. And this is a complex interplay between the three systems. It's not just merely one or the other interacting, but that's at least a baseline for looking at it. The sacral nerve roots, specifically S3, are the primary targets for sacral neuromodulation, at least. We'll talk briefly about some of the new studies going on with implantable tibial nerve stimulation. And essentially, the goal is to help modulate these reflexes so as to rebalance some degree of overactivity. So talking about one of the main indications for using sacral neuromodulation is overactive bladder, which is essentially a symptom syndrome. It's not a disease in that it's a collection of symptoms or signs, which doesn't necessarily have a clear single pathophysiology behind it. And so primary definitions coming from, this is ways back now, 1997, is defined by the presence of urinary urgency, and that can be with or without incontinence, often accompanied with frequency and nocturia in the absence of a underlying metabolic or pathologic condition that could cause this. And notably, when we look at urodynamic findings, we do see detrusor overactivity in a large fraction of these. About 83% of patients with detrusor overactivity do have overactive bladder, but the two are not truly synonymous, and only about 64% of patients with overactive bladder do have urodynamic findings of detrusor overactivity. So it's again, I think, confirming that it's not that the detrusor overactivity isn't it's not a pathognomonic finding for this, that there's multiple things going on behind it. It's a very common disorder. There's several studies that have looked at prevalence across the U.S. population, and ranging between 6 to 16% of the adult population. We've got a few tables here that on the higher end is from this Noble study. And not all of these are severe enough to motivate treatment. So, I mean, that's, only the people who are exceptionally bothered by it do. Up to a third of those can be affected with incontinence or moving into that OAB wet category, with frequency increasing with age. It's depicted there. There are, again, talking about how this is not a disease, but rather a symptom syndrome. There are a number of proposed pathophysiologies behind this, and we'll go through some of these briefly. This is in the neurogenic model. Essentially, there's a suggestion that there's reduced central inhibition uh, of detrusor activity. This could also be due to damage of the axonal paths or the lower components of the innervation. And this decreased inhibition leads to increased afferent signals and can lead to both subjective increased feelings of urgency and also compensatory enhancement of excitatory transmission in the micturition reflex.
Hey, Hunter, let me ask you a question. Go
Yeah.
back to that. So, how do you, in common words, describe reduced superpontine inhibition?
I think like a lot of the components of the um, like you might think of the central nervous system or that suprapontine component of the brain as kind of damping down signals. And if you're not having the appropriate damping down, then the signals are amplified. It's similar to how you get spasticity in like spinal cord patients.
Okay.
If
So, do you think a fourth grader would understand that? How do you
How
just,
would I explain that to him?
yeah, just explain it.
Yeah,
Is it a conscious or subconscious thing?
subconscious.
It can be both.
Okay.
So to me, it's more the gray matter actually inhibiting a void. And this is important, and I'll tell you why in a minute. But so it's the gray matter suppression of voiding. It's something we do all day long. If we're seeing patients, we know it's not appropriate to pee in our pants. So we're suppressing this increasing bladder filling sensation that we want to urge. And this superpontine suppression, whether it's at the subconscious or conscious level, is not enough for certain patients. And in fact, they just cannot suppress it. And in the extreme sense, they are wetting or incontinent before they make it to the bladder, to the bathroom, right? Which would be urge incontinence, or they're just going frequently. And it's important to understand which patient does not have that suprapontine
Mm,
inhibition and which patient does but does not care or is what we would call dementia and early signs, and they just don't really care
mm,
to
mm,
suppress it. And if they're peeing in their pants,
mm,
they're doing it because they no longer care about the social acceptance.
mm.
These are very important people to identify when you're talking about doing a surgical procedure like neuromodulation. That's the only reason I pointed out. You gotta pick your patients very carefully for this intervention.
You're saying because those dementia type patients, they may not experience improvement if it's a lack of voluntary.
Correct. If they don't care, the stimulator is not going to make them
Mm,
care.
yeah.
If they wet, and I say this because there is such a high prevalence of urinary incontinence or urinary symptoms that mimic this in early onset dementia, and it's often before the dementia has been diagnosed. And so, the more and more I do this, then less and less aggressive I'm becoming with certain populations. And these are our geriatric patients, and a lot of them fit in this category.
Thank you, Dr. Costa, for that insight. Um,
Joe, clinically, how do you make that decision, Joe? We are suspecting dementia, and in those patients, we think this may not be as effective.
I think that I don't go as far to make the diagnosis or anything like that because I don't propose to be an expert. But I think when you look at their support system and their decision making and their comprehension of things, you have to take that all into effect. I mean, we get so worried about prescribing an anticholinergic. Um, Imagine what are we going to get by implanting a stimulator? And I think you really got to feel comfortable about that patient's overall decision making, caretaking, support structure before you go do this, because the failure rate in these is so high. And I think the failure rate in stimulators over 5 years can be very high. And I think a lot of it has to do with the initial patient selection. And I'm saying this because I'm inheriting all kinds of failed stimulators from all over Jacksonville. And so if they have a prior urologist that's implanted, I send them back.
Yeah. And the complications are relatively low, is that right, Joe, for this procedure?
Yes, the complications rate is low, uh, but it's a safe procedure, and so it gets done safely, regularly without incident, and that's fine. A geriatric patient, typically any patient can tolerate this procedure
Yeah.
just fine.
Yeah. So the downside is it may not be as effective as we want, but other than that, because it's a safe procedure, there's really no downside to trying this. And because we go through phases, we do temporary pacing, and then before we put the permanent one, is that right?
No, I don't. I don't agree with that. I
Okay.
think that it's 2 trips to the OR and then a lot of sometimes copay expense out of the patient's pocket, and then they become very frustrated with it. And then the number of follow-up visits that are required for this, you can just ask the APPs, how post-implant some of the stimulators can go.
Okay.
The amount of support and time you spend on this um, makes me want to choose my patients much better.
Okay. Thank you, Sean. Yeah.
Thank you. Um, uh, Another proposed model for overactivity or overactive bladder is a myogenic model, still with some degree of denervation, but leading to actual alterations within the smooth muscle and increased ability of the smooth muscle cells to lead to adjacent contractions, which can lead to coordinated myogenic contractions and increased bladder pressure. Um, and there's also the neurogenic myogenic model from Anderson, proposed to result from increased leakage of acetylcholine from the parasympathetic nerves into those adjacent detrusor muscle cells, leading to small degrees of motion of the detrusor bundles and increased activation of the afferent signals with that subjective urgency. And then kind of a not particularly well defined in my impression, neuromyogenic model with just autonomous activity of the bladder smooth muscle. And then some other authors have proposed the importance of the urothelium itself due to the release of compounds there, including acetylcholine and ATP, which can lead to activation or decreased expression of nitric oxide, or inhibitory factors, which can lead to increased afferent nerve activation. So briefly, I think we're mostly familiar with this, but the sacral neuromodulation is it's a long-term, potentially reversible in that the stimulator could be removed or just turned off and deactivated, but delivers relatively low voltage electrical current to the sacral nerve roots, S3 in particular, and helps to normalize the communication between the bladder and the CNS. Consists of the implanted pulse generator here, typically in the upper portion of the buttocks. The lead which goes through the S3 foramen near the sacral nerve, and then the external programmer In terms of mechanism of action, okay, the sacral neuromodulator stimulates the somatic afferent nerves in the spinal cord, and this may inhibit the bladder sensory pathways as well as the reflex bladder hyperactivity. This generally does not affect the efferent pathways so as to not suppress voluntary voiding. In terms of the history of neuromodulation, in the 1960s and 1970s, there were some studies in canine models where it was identified that stimulation of the sacral nerves led to detrusor contraction and resulted in voiding. And in 1989, there was a paper on the first use of this in human subjects. There was, and I was actually not aware of this particular device, the FinTech Brindley external bladder controller, but this was employed in 1986 for patients with spinal cord injury, and essentially it allowed spinal cord injury patients to void volitionally, but required a fairly invasive procedure in which the an intradural procedure in which the dorsal nerve roots were cut with the dorsal rhizotomy, but had fairly good outcomes in that regard. Dr. Costa, do you have any experience with this? I have never seen.
The only experience I had is when I did a neuromodulation review as a fellow, a literature review, and wrote a chapter. And so FinTech Brindley's been around since like 1999. And it really never took on because the dorsal rhizotomy is a very morbid procedure. You lose a lot of other function. And you had to turn the stimulator on to empty the bladder. It wasn't really volitional voiding with a suprapontine
Right. Yeah.
ability. You had to actually turn on a stimulator, and there was still a lot of secondary musculoskeletal spasm while the stimulator was running and the patient was trying to void. So, there was technically success in terms of bladder emptying, but I think the squeeze to get the juice was really not worth it to most clinicians and patients, and therefore it never really took off.
Okay, thank you. And I was under the impression that that was part of the doing the rhizotomy was the goal to try and help with some of the spasticity, but if it was still experienced.
Yes, despite that, there's still quite a bit of spasticity, and the rhizotomy itself created a loss of other functions that they may have wanted to keep.
Yeah.
And so it really just wasn't worth it.
And I think, also definitely restricting you to, if you're going to have to do that rhizotomy, a more complete spinal cord injury would be the only, because if you have other function down there and you have to cut those, if you have an incomplete spinal cord injury, it's even less applicable.
Correct. And that's a big emotional thing.
Yeah.
You've seen it. These fairly newly spinal cord injured patients don't even want to go on anticholinergics because they're afraid that their bladder will stop recovering. That they'll stop trying to get squeezed back. And so it's that for all the above, it was a great concept, but never really became more refined.
Thank you. And then with the arrival of the InterStim system in the 1990s, we obtained the first fully implantable percutaneous device for sacral neuromodulation. It was approved in 1997 for refractory urgency frequency and urgent continence. In 1999, it gained approval for non-obstructive urinary retention, and in 2011 for fecal incontinence. Those are the primary indications for use. Typically, or we typically use it in our practice for those who have failed or intolerant to the conservative therapies such as behavioral interventions or pharmacologic treatments, and both for the overactive bladder urgency frequency as well as incontinence episodes. It does, however, have some good success with non-obstructive urinary retention. I know I've seen some patients in Dr. Costa's clinic with that, things like Fowler syndrome or idiopathic urinary retention without urodynamic findings of mechanical obstruction and fecal incontinence, as we described. Off-label indications include chronic pelvic pain or interstitial cystitis. Some patients experience improvement with that. And actually, use in neurogenic bladder patients is also off-label at this time, as far as I know. Yeah, it is kind of interesting with some of the history there that part of the issues with MRI, but that's actually changing now, MRI compatibility with some newer models. So I put in here the guidelines or an algorithm. This is the 2024 AUA SUFU guideline or workshop, which or algorithm, I suppose, which talks about initial evaluation for patients with urgency frequency, history, physical, ideally bladder diary would be great. UA to help rule out infection or hematuria in terms of those other pathologies that could be causing this. PSA, if appropriate, if in the appropriate population. And if there are issues with voiding symptoms, then getting a PVR is helpful as well. Urodynamics really only indicated if there's degree of diagnostic uncertainty. And I think, while we do primarily use this as a refractory or third line therapy after behavioral interventions, which have obviously low risk in terms of decreasing voiding, behavioral therapies, time voiding, avoiding bladder irritants like caffeine, spicy foods, alcohol for some people, and pharmacotherapy, including antimuscarinics or beta-3 agonists, before proceeding to these, what have previously been considered third-line therapies. This 2024 guideline did indicate that minimally invasive therapies can be offered without a trial of those other ones. You just need to discuss those risks and benefits in a shared decision-making model. I still don't think I would proceed to sacral neuromodulation without trying other things, but I think this is more in light of things like percutaneous tibial nerve stimulation that are, while still procedural, do not involve a permanent implantation or things like Botox.
Hunter, I think that's correct. I agree with the way that you're thinking about it is in line with how I think about it. I think for a implantable device such as this, I much rather prefer they fail lesser procedures, and most insurers, all insurers, won't approve the procedure unless they've failed other non-invasive like oral medication therapies. But peripheral nerve stimulation is different. It's less invasive, and it's something that I'm actually considering adopting because there's newer technologies. Maybe you're going to talk about them. So anyway, I agree with you on what you've said.
Thank you, Dr. Costa. And I'm not going to go into those too much. They did talk about them at that conference I went into, both the percutaneous tibial nerve stimulation and also there are two new implantable devices, the eCoin and then the Blue Wind Revi, which just as a brief aside are devices that are implanted near the ankle and stimulate the tibial nerve, which is one of the branches of the sacral nerve and has similar effects to sacral neuromodulation, but in a more peripheral stimulation and potentially less invasive, which, I thought those were very interesting.
Yes. I
And
agree. And I
I,
think eCoin is actually one I'm considering adopting.
well, I would be excited to hear more about your plans on that. Um,
Joe, can I
Okay.
ask another basic question, Joe? I'm just trying to draw analogy here between BPH, IPP management, and this management. The shift I'm noticing in the benign world is this is a traditional approach where we try medicines first, and then gradually escalate it to more invasive procedures. And now in the BPH world, this discussion, should we do UroLift instead of Flomax? That way patients don't have to be on meds. I'm doing the same thing with IPP. We don't have to fail so many medical management before going to IPP. In this world with OABs, is that thought process evolving, or we still sticking to the traditional method here, John?
It's evolving, and it is pushed by the reps. If you ask them, they want you to go straight to intervention. And in some cases, when you have a really effective therapy, it is cost effective if you choose your patient right and you go to the surgical option early. If you weigh the cost of medications over time, there certainly are arguments you can make that it is better. It's really a matter of picking the right patient, and that's kind of what I think surgery is all about, anyways. And that's the art of it. But yes, they are, as a whole, becoming more aggressive with earlier intervention.
Yeah. So, Joe, hypothetically speaking, let's say we have a 40-year-old patient who clearly has overactive bladder and no anatomical causes for it, very symptomatic. We have tried either beta-3 agonists or anticholinergics with minimal effect. Would you feel comfortable going on with a modulator for that patient, or would you still go through things like Botox and tubular stimulation and so on, or adding multiple drugs to see whether they improve?
It depends on the problem, but typically, if they failed multiple medications, at least two, then offer them simultaneously either Botox or neuromodulation. Although lately I've been favoring just going to Botox first. But yes, that's we kind of have an algorithm that we follow and move on for the significantly bothered patient. Typically, those are incontinent patients that are wetting 5, 6 pads a day. They're miserable.
Okay, thank you.
um, and it just in that, Dr. Balaji, in terms of the movement in BPH and this, I wonder how much of the guide, well, one, I think, like Dr. Costa said, is maybe there's advocacy from the device companies or reps about trying these procedural interventions earlier. But if the society guidelines indicate that you don't have to proceed through these things, is it some movement to try to um, help convince insurance companies to pay for it without having to go through multiple lines um, of other therapies? I I don't know.
Yeah, I agree with you. I think with the IPP world, it's entered the guideline that you don't have to wait for failure of all therapies because IPP is so effective that patients don't have to go through a roller coaster knowing whether it will work or not. So the guidelines there says you can proceed. In fact, even in your in-service exams, it's okay to proceed without utilizing all the prior therapies. With the BPH world, it's evolving. I just wasn't sure in the OAB world, but I would imagine it's also would evolve in time because what we really want to do is to go for the most effective option. And like Dr. Costa was saying, if you're able to select the patient right and you know it's going to work,
Yeah,
then why put the patient through the roller coaster of treatments that are going to be less efficacious? So,
yeah, balancing the efficacy with risk.
yeah.
Um, Moving on to the procedure itself for sacral neuromodulation, and starting with stage one. This is normally done as a staged procedure. The main purpose of the stage is to confirm that the procedure will be efficacious for them. And this can be done in two methods. Here with Dr. Costa, we mainly do the 2 OR stay with implantation of the permanent lead at the first stage. But this can also be done with a temporary lead. This is referred to percutaneous nerve evaluation, or PNE. And this is generally done in the clinic in a procedure room and can be done with either fluoroscopic guidance, or actually, I spoke with a number of people at that SUFU conference who did it just blindly with landmarks, which I was pretty impressed with, just because it always seems like a struggle for, or it doesn't seem trivial to do it even with fluoroscopic guidance. So the fact that they're able to do this blindly in the clinic, I was impressed with. But a lot of people, that is their standard practice, and that both saves the patient an anesthetic and also opens up your OR day a lot, because this can be done in a procedure clinic. Um, I'd be interested in hearing your thoughts on PNE, Dr. Costa, or if you've tried it at all.
Hunter, can
Yeah,
I add something?
I've done them blindly.
Okay.
Go
In the-
ahead, Angela. No, go
Yeah,
ahead.
I was just gonna say during some school time in like 2016 when I was with Mayo, the
Yeah.
APPs were doing that, like Q weekly for 6 weeks
Yeah.
treatments, and they were just finding landmarks of the tibial nerve and basing it on, what the patient felt.
Oh, for the tibial nerve stimulation.
Oh, yes,
Okay.
I'm sorry.
Okay.
Yes.
Yeah. Well, we had you.
So-
Yeah.
Yeah, I would say yes to all of it. So the tibial nerve part, I think we are probably going to start dipping our toe into. Hunter, I've been doing for years the percutaneous office-based, landmark-based implants, and they can go well, and sometimes they're not so well. The biggest issue I'm really having is a reliable scheduling system. I think that our clinics and it's just our goals right now are to increase access. And while that is the goal, it is too frequently. How many times have we seen a follow-up patient that the rep was supposed to be there at the same time just for programming?
Yeah.
This requires the rep being present as well. It's not just something you can do and take a shot at it. And so as long as the rep needs to be there and there's this coordination and all that, it's just too difficult to do in the office and not have to cancel the patient because somebody didn't show or something didn't happen. And so because of that, I've just chose to do stage 1 and 2s in the OR because I know I can control that time.
Okay. Thank you. And moving on, just generally in terms of success, defined as a 50% or greater improvement in symptoms, such as voiding frequency or incontinence episodes. When performed in the OR for the permanent lead implantation, equipment includes fluoro, a minor tray, Bovie, although hopefully not too much. And then the implants themselves, as well as a test stimulator. In terms of positioning and setup, generally performed under local with MAC, without long-acting paralytics if general anesthesia is required. This reference suggested using vancomycin and gentamicin given that there's a implanted device, but I think Dr. Costa, we just do for ANSEF with him. And prone with pillows, or I think we use gel rolls under the abdomen. You do need to keep the feet exposed and ideally the anus as well to visualize the bellows response, and that's either with 10-10 drapes or some people talk about using cranny drapes. In terms of landmarks and positioning using fluoroscopy, this is a AP view of the sacrum, and some people describe it as like the elephant's trunk with the medial borders of the foramen here. And then other landmarks are the sacral notches here, labeled 5. And method 1 involves identifying those sciatic notches and then making a line between them, and then 2 centimeters and lateral from midline on the sacrum, and then 2 centimeters superiorly should mark the opening of the S3 foramen. When you're inclining your needle to try and enter that, you need to compensate for the thickness of the subcutaneous tissue, either with making it both higher, like 2 centimeters more superior. And then method 2 is just a landmarks-based method, essentially looking at 9 centimeters off the coccyx. And method 3 discussed the source. This is from University of Kansas. Essentially does the medial lateral positioning from the AP view, but then switches to the lateral view for actually finding the foramen. I thought I had a slide with the hillux there, but in terms of once you've got your initial needle test finder in the foramen, you want to check that it's the correct foramen and you're well located relative to the S3 nerve. And the primary effects you're looking for are the bellows of the perineum with lifting of the anus and pelvis floor superiorly, as well as plantar flexion downwards of the great toe. There can be other toes as well. As well as a sensation in the rectum or vagina or kind of the bicycle seat region, which we ask the patients about. Ideally, you don't want to be seeing these S2 factors such as entire foot plantar flexion. And so it's done with local anesthesia and a skin wheel. You want to try and get both superiorly and medially in the S3 foramen. Talk about testing the responses. Once you have good responses, you make a small skin incision like Seldinger technique along the needle, and then remove the stylet of the needle, exchange it for a directional guide wire. That's what they're showing here. Then the needle is removed and a dilator is introduced over the guide wire, this normal Seldinger technique. And I think this is that step, introducing the dilator, is one to take pause and control on, because one, you can make a false passage, and two, you can, if you really went too far, you could theoretically penetrate the rectum, which would be bad.
Hunter, I would argue that rectal injury is not really the big concern, but if you overpass your dilator, you're going to set your permanent electrode up so that it won't fan out laterally with the nerve root. I'm sure you're about to describe proper positioning of the actual permanent electrode. And I find that if you overpass your dilator, it's much more difficult to get your permanent electrode to sit exactly where you want it to. And so that's the main reason for being very careful about overpassing.
And thank you, Dr. Costa. I think because that dilator is more firm, so you could create a false passage extending anteriorly, as opposed to just pushing out next to the nerve that you want the tines to
correct. Follow. Yes, you don't get it. You don't get that flat lateral trajectory that follows the nerve root that you really want, and instead it almost passes straight down vertically, and it's hard to recover from that. Sometimes I've had to go stick the other side simply because the dilator was overpassed. But it's a big deal.
And that positioning, you want it going both inferiorly and then laterally along that S3 nerve root. The tined lead is inserted through the introducer sheath, and then the you ideally want there are 4 electrodes here, 0, 1, 2, 3, and you want the anterior table of the sacrum to be about midway between leads 2 and electrodes 2 and 3. And then want to retest there when that's in position to confirm that all of those electrodes are showing good responses at less than 2 milliamps. So there's good conduction between the nerve and the electrodes. And then that tined lead is held in place and the sheath is pulled back over it, and that allows these tines to deploy and hold it in a fixed position. In terms of the stage procedure, the second component's done. We typically do about 2 weeks afterwards with permanent implantation for those patients who had successful response to stage 1. Those who don't, then this is a removal procedure. And I guess that's one other downside of if you did the PNE is that now you have to, maybe you got good response from the location of the PNE electrode, but are you getting your real leads back in the same response, same location, hopefully. But in this case,
yeah, theoretically, Hunter, if you can get it with the PNE, you're going to get it with the permanent. The bigger issue is if you get a negative PNE test that doesn't work.
Yeah.
The bigger question is, would you have gotten them with a permanent electrode? And did you really just get a false negative? And that's another thing about PNEs, because they're more tenuous wires. They can move out of place with the patient movement. So that's the bigger issue. It's not so much, can I recapture them with a permanent electrode? Was my percutaneous test really false?
And it sounds like most people, if you have a non-response to PNE, most people try it again with the permanent electrode in the OR. So yeah, then you're putting someone under 3 procedures potentially, which as opposed to just at most 2 if you do it the first stage in the OR. Oops. And in this stage, implant the IPG in a subcutaneous pocket and then tunnel the connector lead to the permanent lead that's already tunneled. You need to avoid strenuous activity, allowing that to heal, and then close follow-up with the device rep for programming. In terms of long-term outcomes and efficacy, we'll go over some of the initial studies on the next slide, but good long-term success rates as both for OAB and urinary retention, as well as fecal incontinence. Longevity initially for some of the initial versions of the InterStim was 5 to 10 years, but now I think both InterStim and Exonics have rechargeable devices. So this is from a 2018 study in the Journal of Urology, looking at long-term outcomes, long-term follow-up results for overactive bladder treated with sacral neuromodulation. And you can see that even up to 60 months, with pretty good follow-up, 150 patients out of the initial 229 they have in this completers analysis, that about 80% of them and it remained satisfied, and that was or remained responders, which was classified as that over 50% improvement in either incontinence episodes or urinary frequency with to less than 8 voids per day. In terms of issues in follow-up, There can be loss of efficacy over time, either due to lead migration, breakage, changes in scar tissue, or a need for programming adjustments. There'll be some degree of pain, but most patients seem to tolerate it pretty well if the IPG is positioned well in a pocket that they're not going to sit against. And infection can be a concern as well with the foreign body. So in summary, it's overall safe, effective, and reversible therapy for refractory OAB, urinary retention, and fecal incontinence. It helps address the abnormal signals in the afferent innervation, but like Dr. Cost talked about, patient selection is really important for seeing who's going to benefit from this. Future directions include leadless or even smaller IPGs, although I mean, the Axonics one is quite small, as is the newer InterStim version. And the newest versions are MRI cleared for 1.5 Tesla magnets, which actually it seems like most MRIs nowadays are 2 to 3 Tesla. So it's still something. And then I think didn't talk a whole lot about tibial nerve stimulation, but that's more peripheral and potentially less invasive with similar results, but not truly sacral neuromodulation. Got some time for questions, or we also have SASP questions if anybody wants to go through those. Yeah, if anybody has other questions, we can go through those, or else we can do some SASP questions.
Hunter, this was a great talk. I did a couple of these stage 1s yesterday with Dr. Costa. Looking forward to the stage 2s and really understand these operations. But I really appreciate you going into the pathophys of all this. So thanks for putting this together. I don't really have any questions. I would love to do some SASPs if you want. Whatever you want to do, man. But I just thanks for putting this together. Appreciate you on this.
Thank you, Tom. I appreciate it. Hope it was helpful.
Hunter, if you have time and everybody else has time, it's fine. Everybody can also go do what they need to do. But, SAS questions are always a good review.
Yeah, we got about 7 minutes. If you have prepared questions, we can go through them further. So the residents are okay with it. Okay, why don't one of our junior residents take this question, please? Okay.
Well,
I think take it right now. He's with me, so he's gonna jump on here.
Okay. A 47-year-old woman is undergoing a percutaneous test stimulation of a lead for sacral neuromodulation. Plantar flexion and rotation of the foot is noted along with sensation in the buttocks. The next step is to A, maintain lead and discharge home. B, place the lead 1 foramen higher and retest. C, place the lead 1 foramen lower and retest. D, advance the lead deeper into the foramen and retest. And E, withdraw the lead to a more superficial location in the foramen and retest. Okay. This is a tough one. So we want to go for the S3 usually. Plantar flexion, if I'm not mistaken, is